Before I explain anything, do something. Pick up your phone and open the camera. Hold it at eye level, directly in front of your face, in whatever light you are currently in. Take a photograph. Now look at it. Not at your face as a whole, at the two sides separately. Look at the nasolabial fold on the left side and then on the right. Look at the jowl tissue along the left jawline and then the right. Look at the crow's feet at the outer corner of each eye. Look at the fullness of each cheek. If you are a habitual side sleeper, and approximately 70% of adults are, one of those sides will show measurably more of everything that the aesthetic medicine industry describes as signs of aging. A deeper nasolabial fold, a more prominent jowl, more orbital puffiness, more lateral compression lines. The asymmetry you are looking at right now is not genetics. It is not coincidence. It is a decade or more of nightly mechanical force applied to one specific side of your face while the other experienced none. And the side that received the force is the side that looks older. Welcome to Dr. Mylan Health. Subscribe and hit the bell. Our complete anti-aging book covers every mechanical, dietary, and environmental mechanism that determines how the face ages, organized by what the research shows rather than what the product industry promotes. Link in the description and in the comments. Now let me explain exactly what you just found in that photograph and why the asymmetry will continue widening on that side until something in the 8-hour window that produces it changes. The phenomenon you are looking at has been documented in medical literature since at least 2013, when a study published in Aesthetic Surgery Journal examined the facial asymmetry patterns of long-term side sleepers using three-dimensional facial imaging technology. The researchers documented consistent, measurable differences between the sleep side and the non-sleep side across multiple facial zones: the nasolabial fold, the malar region, the periorbital area, and the mandibular border. The sleep side nasolabial fold was deeper. The sleep side jowl was more prominent. The sleep side crow's feet were more pronounced and ran at a different angle than those on the non-sleep side, an angle consistent with pillow compression rather than with the muscular pull of the orbicularis oculi. The study's conclusion: that sleep position produces measurable unilateral facial aging that mirrors and amplifies bilateral chronological aging on the compressed side, was published in a peer-reviewed surgical journal. It was noted by aesthetic surgeons who began accounting for sleep side asymmetry when planning filler placement for their patients. It was never communicated to those patients as information they could act on preventively. The information flowed in the direction that generates procedure revenue, not in the direction that would have allowed the patient to prevent the asymmetry from developing in the first place. Understanding why one side ages faster than the other requires understanding that the face is not a solid structure sitting passively on a neck. It is a layered system of mobile components, fat pads, retaining ligaments, skin, muscle, and fascia, all of which respond to mechanical forces applied to them. And when one side of that system is pressed against a surface for 6 to 8 hours every night, the mechanical forces applied to that side are not trivial. They are sustained, repeated, and directional. They accumulate, and their cumulative effect on each layer of the facial structure is what produces the asymmetry visible in the photograph you just took. The first layer is the fat pads. The face contains 12 distinct fat compartments distributed across the deep and superficial planes. The malar fat pad, the nasolabial fat, the jowl fat compartment, the suborbicularis oculi fat. Each one is a mobile structure that responds to sustained directional force. When the face is pressed into a pillow, the fat pads on the contact side are subjected to a compression force that pushes them in the direction of least resistance. For a person sleeping on their right side, the right malar fat pad is compressed toward the nasolabial fold. The right jowl fat is compressed toward the mandibular border. The right orbital fat is pushed forward against the orbital septum. Night after night, this compression is repeated in the same direction. And fat pads that are repeatedly pushed in a specific direction eventually settle in that direction, because the retaining ligaments that hold them in their correct anatomical positions are made of collagen, and collagen under repeated unidirectional loading undergoes a process called creep, the gradual permanent deformation of a tissue under sustained mechanical stress. The right retaining ligaments elongate under the repeated compression and settling cycle. The right fat pads begin resting in a slightly more inferior and anterior position with each passing year. The right nasolabial fold deepens. The right jowl becomes more prominent. The face develops an asymmetry that is not the product of different genetics on the two sides of the body. It is the product of different mechanical histories. The second layer is the lymphatic system. The lymphatic capillaries of the face drain toward the preauricular and submandibular lymph nodes. This drainage is passive. It is driven by the pressure differential created by micromuscular movement, by respiration, and by gravity. During sleep, micromuscular activity is reduced. Respiration drives some lymphatic movement, but less than waking activity. And gravity is the dominant force. For the downward-facing side of the face, the sleep side, gravity opposes lymphatic drainage. The lymphatic fluid that accumulates in the facial interstitial tissue throughout the night has to flow upward to reach the drainage nodes, and upward flow in a passive system against gravity is significantly slower than downward flow with gravity. The result is that the sleep side face retains more interstitial fluid than the non-sleep side across the same night of sleep. The sleep side nasolabial fold appears more prominent because the tissue on that side is more fluid-loaded. The sleep side jowl appears heavier because the fluid-retained tissue adds apparent volume to the fat that has already been mechanically displaced. The sleep side under eye appears puffier for the same reason, and because chronic interstitial fluid retention in a tissue zone produces a chronic low-grade inflammatory state in that tissue, through the same mechanism that any edematous tissue experiences inflammatory activation, the sleep side also experiences more MP-driven collagen degradation than the non-sleep side over the same period of time. The asymmetry has a circulatory dimension, not just a mechanical one. The third layer is the skin surface and the creases that compression produces in it. This requires a specific distinction that most people have never been given the conceptual tools to make. There are two fundamentally different types of facial lines. Expression lines, the lines produced by facial muscle contraction, which run perpendicular to the direction of muscular pull, and compression lines, the lines produced by skin being repeatedly folded against a surface, which run at whatever angle the compression geometry produces. Expression lines respond to Botox because they are driven by muscle contraction, and blocking the contraction removes the force that creates them. Compression lines do not respond to Botox because they are not produced by muscle contraction. They are produced by the physical geometry of a face pressed against a pillow. A Botox injection in the orbicularis oculi relaxes the muscle and softens the expression-driven crow's feet at the lateral orbital zone. It does not address the additional compression lines that run at a different angle on the sleep side, lines that were produced by the pillow, not by the muscle, and that deepen independently of the muscle's activity state. This is why sleep-side crow's feet often fail to respond to Botox as fully as patients expect. There is a compression component that the toxin cannot reach. And it is why aesthetic surgeons who account for sleep position asymmetry achieve better symmetry outcomes than those who do not, because they are treating the correct subset of lines with the correct intervention, rather than applying the same bilateral treatment to an asymmetric bilateral problem. The fourth layer is the dermal collagen architecture itself. Compression creases are not merely surface indentations. They represent a structural rearrangement of the collagen bundles in the dermis of the compressed zone. In healthy dermal tissue, collagen fibers are arranged in the basket weave pattern that provides flexibility in multiple directions. In tissue that has been repeatedly compressed in a specific direction, the collagen fibers begin to align preferentially in the direction perpendicular to the compression, a structural adaptation that increases the tissue's resistance to the repeated compression load at the expense of flexibility in other directions. This realignment is visible in histological analysis of compression crease tissue compared to adjacent uncompressed tissue of the same age. The compressed side dermis shows more organized, less flexible collagen bundle orientation, and over time, as the fibers that maintain their original basket weave orientation are replaced through natural turnover by fibers that deposit in the compression-adapted orientation, the structural difference between the sleep side and the non-sleep side becomes progressively more pronounced. The line deepens not just because the surface has been pressed, but because the tissue underneath has structurally adapted to the repeated pressing and now holds the compressed shape more firmly with each passing year. The research documenting these mechanisms is not obscure. Beyond the 2013 Aesthetic Surgery Journal study, multiple subsequent publications have examined sleep position and facial asymmetry through clinical photography, 3D imaging, and patient self-report of sleep position. A 2016 paper in the Journal of Cosmetic Dermatology confirmed that patients who had slept exclusively on one side for more than 10 years showed statistically significant differences in nasolabial fold depth, jowl tissue position, and periorbital skin texture between the two sides. A survey study published in Sleep Medicine Reviews found that the majority of long-term side sleepers who were shown standardized photographic comparisons of their own two facial sides immediately and without prompting identified the sleep side as appearing older, without being told which side was their sleep side. The asymmetry is visible. It is recognized as aging. And it is produced by a behavioral pattern that none of the participants had been advised to change by any healthcare or aesthetic provider they had encountered. The mechanism is in the literature. The advice is not in the consultation room. The consultation room profits from treating asymmetry after it develops, not from preventing it before it does. The practical response to what you found in that photograph has three components that address the three primary mechanisms. The first is sleep position. Back sleeping eliminates the unilateral compression entirely. Both sides of the face receive identical mechanical conditions during sleep, no compression on either side, no asymmetric lymphatic drainage, no compression crease repetition. For people who cannot maintain back sleeping through the night, a cervical positioning pillow or a rolled towel against the back prevents the body from rotating to the preferred side during the lighter stages of sleep when conscious resistance is absent. This is not comfortable initially. The body has been trained to a preferred sleep position across years or decades of habituation. The discomfort of the retraining period is temporary. The asymmetry it prevents from deepening further is not temporary. The second component addresses the sleep side specifically during the transition period, a ceramide-rich barrier product applied to the sleep side nasolabial fold, jowl zone, and lateral orbital area before sleeping provides the ceramide content that compression friction is disproportionately depleting on that side compared to the non-sleep side. This does not prevent the compression. It partially replenishes what the compression removes. The third component is a morning bilateral lymphatic drainage massage, 2 minutes, both sides simultaneously, using upward strokes from the chin toward the preauricular lymph nodes, that partially compensates for the asymmetric overnight drainage by manually clearing the fluid retention that accumulated on the sleep side during the night before the EMP-driven inflammatory activation it produces has time to run its full course in the tissue. The photograph you took at the beginning of this video is evidence. It is not a cosmetic irregularity that happens to exist on your face. It is a precise record of which side of your face has been in contact with a surface for 6 to 8 hours of every night across however many years you have maintained your current sleep position. The deeper nasolabial fold is there because the fat pad on that side has been displaced in that direction more than the other. The more prominent jowl is there because the retaining ligament on that side has been loaded asymmetrically for years. The additional compression lines at the lateral orbit are there because that specific angle of pillow contact has been printing itself into the dermal collagen of that side repeatedly since the first night you adopted that sleep position. The asymmetry will continue widening on that side at the same rate it has been widening, unless the 8 hours that produce it change. No filler applied to that side addresses the nightly force that is deepening the fold the filler is temporarily filling. The force continues. The fold continues. The appointment recurs. Our complete anti-aging book covers every mechanical, postural, and environmental mechanism that determines how the face ages asymmetrically and symmetrically, with the complete protocol for addressing each cause rather than each visible consequence. Link in the description and in the comments. If this opens something for you, subscribe and share it with everyone you know who has looked at photographs of themselves and wondered why one side of their face looks older than the other. Now they will know. The next vault opens soon. I'm Dr. Maylin. Thank you for listening to Dr. Maylin Health. There is a specific observation about the photograph you took that most people miss on first viewing, and that becomes one of the most clinically useful self-assessment tools available once it is pointed out. The sleep side nasolabial fold does not simply appear deeper than the non-sleep side. It also angles slightly differently. On the non-sleep side, the nasolabial fold runs at the angle produced by the downward displacement of the malar fat pad under gravity, a relatively consistent angle across most people of similar age and facial structure. On the sleep side, the fold runs at a composite angle, the gravitational component plus the lateral compression component from the pillow. The result is a fold that both deeper and slightly differently directed than its contralateral equivalent. This directional difference is one of the diagnostic signatures that experienced aesthetic surgeons use to identify sleep position asymmetry in clinical photography, and it is one of the reasons that symmetric filler placement, the same volume applied to both sides, often produces results that still look asymmetric. The cause of the asymmetry has a directional component that product volume cannot correct. Restoring volume to a fold that is both deeper and differently angled than its contralateral equivalent requires asymmetric placement accounting for both the depth difference and the directional difference. Most filler consultations do not include a sleep position history. They begin from the photograph of the asymmetry and work backward to a treatment plan, not forward from the cause to prevention. The treatment plan generates revenue. The sleep position history generates nothing except the possibility that the patient might prevent the asymmetry from returning after treatment, which is, commercially speaking, the least desirable outcome for a practice built on repeat injection appointments. There is also a difference that becomes apparent in the orbital zone that the nasolabial comparison does not capture. Hold the photograph up again and look specifically at the lateral orbital zone, the area at the outer corner of each eye extending toward the temple. On the non-sleep side, the lines you see there will be oriented primarily in the radial pattern of the orbicularis oculi muscle, lines that fan outward from the lateral canthus in directions consistent with the muscle's circular contraction pattern. On the sleep side, you will see those same radial lines plus a set of additional lines oriented differently. Lines that run roughly perpendicular to the direction the pillow contacts the skin, at the specific angle of your typical sleep position. These additional lines are the compression creases discussed earlier, not produced by the muscle, not addressable by the toxin, not reducible by any topical product, because they represent structural collagen rearrangement in the dermis of that specific tissue zone. They are visible evidence of the precise angle at which your face has been meeting the pillow surface across your sleeping life. If you trace the angle of those additional compression lines and extend it, it points directly to the contact geometry of your typical sleep position. Your face has been recording its own mechanical history in real time. The lines are the record. And they will continue being added to that record every night until the recording conditions change. The decision about whether to change those conditions belongs entirely to the person looking at the photograph. Some people, having seen the asymmetry and understood its cause, find the transition to back sleeping straightforward and commit to it within days. Others find it genuinely difficult. The preferred sleep side has been associated with sleep onset, comfort, and years of habituated neural pattern that reasserts itself the moment conscious vigilance drops during sleep transitions. For those people, the cervical positioning solution is more reliable than willpower alone. A pool noodle or firm cylindrical bolster placed along one side prevents the body from rotating without requiring conscious maintenance of a position during sleep. It is not elegant. It works. The asymmetry you found in that photograph is currently approximately as asymmetric as it will be when you wake up tomorrow morning if tonight's sleep position does not change. It will be slightly more asymmetric than it will be when you wake up on the morning that follows a year of unchanged sleep position. The rate of widening is gradual. The mechanism producing it is consistent, and the intervention that stops it costs nothing except the discomfort of sleeping in a new position until the new position becomes the habituated one.